Welcome to the lecture on detection, diagnosis, and treatment planning of dental caries. The topic learning outcomes for the current lecture are to describe and demonstrate visual, tactile, and radiographic methods of caries detection, develop a treatment plan based on severity of the lesion and susceptibility of the patient. Coming to introduction. So there is a paradigm shift in how we manage dental caries. It has changed from the era of G.V. Black, where treatment was based on concept of extension for prevention, to current concept which is based on minimal intervention dentistry. Minimal intervention dentistry is based on prevention for extension. The principles followed in minimal intervention dentistry are accurate diagnosis following newer classification of caries, individualized risk assessment, focus more on remineralization of incipient lesions, reduction of cariogenic bacteria, minimal surgical intervention, repair rather than replacement of tooth structure, last but not the least, follow-up and recall. Coming to the first step of caries management, identification. The important aspects of identification includes obtaining history and other relevant information related to medical and surgical history. Make a clear note on dietary habits, oral hygiene habits, and dental history. Carefully examine all the soft tissues and hard tissues and do a radiographic assessment if needed. Make a note on other etiological factors which may increase the susceptibility of the patient to dental caries. During examination, visual detection of the caries should be done in a dry field which is very well illuminated. Do not use sharp probes, use only blunt probes to avoid damaging the external surfaces of the tooth. In patients having a lot of plaque deposits, it's always better to do the caries detection after the plaque removal. So it's evident from the picture shown here. On the top right corner you can see a central incisor. Okay, there is no evidence of caries, but after the plaque removal a cavitated lesion can be clearly detected at the cervical area. Other than clinical examination, radiographic examination is also a very valuable tool to detect dental caries, especially in case of proximal lesions. This allows detection and follow-up of initial lesions at which remineralization therapy has been indicated. Any methods of caries detection other than the digital and tactile method of caries detection, as it has been summarized on this slide. We are going to discuss few of these newer methods of caries detection in the next few slides. So the first one is fiber optic transillumination. So it's like a probe-like device which is can be used to detect dental caries, as well as if there are any fracture lines which are present on the tooth which are not evident by a visual eye. So in fiber optic transillumination, the enamel lesions usually appear as a gray shadow, whereas dentinal lesions appear as orange brown or a blue shadow. If the fiber optic transillumination is combined, or if you can see these images on a computer screen, it is called as a digital fiber optic transillumination. More advanced method of caries detection is a quantitative light induced fluorescence QLF, based upon the principle that fluorescence of the tooth changes when the mineral density of the enamel and dentine changes. So there is increased porosity which leads to reduced fluorescence when caries is there. Laser induced fluorescence, which is called LF. So here we are going to discuss an instrument called Diagnodent by Cavo, which generates very simple numerical index that quantifies demineralization and remineralization of the tooth. The metabolic products of the bacteria absorbs red laser light and emit light which is channeled through a handpiece, and which shows as a numerical value for presence of carious tooth structure. So whenever there is a carious tooth structure, the fluorescence increases and the number increases. Transillumination with near infrared light can also be used for detection of dental caries. Most of these techniques are in experimental stages. Here the tooth is illuminated with a near infrared light if there is caries, which will appear as dark since less light reaches the detector. Caries detection dice is and one of the older methods of caries detection. According to the principle, the detecting dye stains the demineralized organic matrix of dentin. However, since it does not stain bacteria, it should not be used as a sole diagnostic technique. So there are chances that you may remove more dentin, which is demineralized. Okay, but there are chances of remineralization if you retain it. So coming to the second step of caries management, which is called as risk assessment. This is one of the most important steps of caries management. The caries risk assessment is usually done to determine the susceptibility of the individual to develop new caries lesions. It can be done by examining the diet, saliva, oral hygiene status, as well as bacterial count. Let's look at the flowchart, how the susceptibility of the patient is affected by various factors which has been discussed in the previous slide. So looking at the diet, if the patient takes a more carbohydrate rich diet, which in turn increases the higher bacterial load, this higher bacterial load will produce more bacterial acid production, leading to increased risk of tooth decay. Poor oral hygiene again leads to higher bacterial load, which again leads to higher increased bacterial acid production and increased tooth decay. Poor quality or quantity of saliva lead to decreased buffering capacity and lower salivary ions, which are required for remineralization, again leading to increased risk of tooth decay. Diet of the patient can be determined by asking patients dietary habits questions. The oral hygiene status also can be determined by taking a careful history, as well as during the examination you can see the plaque and calculus deposits. Now, how do we determine chair side the salivary gland functions? Okay, there are very simple tests which can be done chair side to determine the salivary gland functions of mainly of this minor salivary glands. What you do is that with your thumb and index finger carefully avert the lower lip, and after carefully averting the lower lip you take a blotting paper and place it on the lower lip. So when you place the blotting paper on the lower lip, you can see the small droplets which are forming on the blotting paper. This is due to the secretion of the saliva from the minor salivary glands. So if you make a note of the time after you place the blotting paper and the formation of the small droplets, then you can determine the salivary gland function. If the droplets are formed with less than 30 seconds, then that means the salivary gland function is favorable. If it is between 30 to 60 seconds, the function is moderate, and if it is greater than 60 seconds, that means the salivary gland function is unfavorable. So in patients with unfavorable minor salivary glands, we can expect the caries susceptibility to be higher. Check the quality of the saliva, okay, in a patient. You just ask the patient to lift the tongue and touch the palate. Okay, slowly the saliva forms on the floor of the mouth. Okay, so if you look at the saliva which is forming on the floor of the mouth and on the cheek, if the saliva appears watery with the pooling and forms a shiny thin film, okay, this is a good quality saliva. If the saliva is there is no pooling and it appears to be little sticky, or it appears to be thick, ropey and frothy, okay, then it is a poor quality saliva. There is a test called web test. Just take the reverse end of the mouth mirror and try to touch the saliva, and try to lift with the reverse end of your mouth mirror or probe. If the saliva which is breaks immediately, that means the saliva is good quality. But if it is poor quality saliva, it forms strings. Okay, so that means it's a very ropey and stringy saliva. So in patients with having this kind of saliva, the susceptibility of the caries is more. You can also detect the salivary pH using a simple test which is called as traffic light test. So dribble a small quantity of saliva into the container and insert a pH paper and obtain the value after 10 seconds. Okay. So if If the color on the pH paper is red, that means the pH is less than 5.8, it's unfavorable. If it is between 5.8 to green 6.8, it will appear as orange color, and if it is greater than 6.8, which is appears as green color, which is a more favorable saliva. Okay, then you can also make a note on assessment of salivary flow. You ask the patient to chew on a paraffin or gum for 5 minutes and collect the saliva into a container. When measure the volume of saliva, so if the amount of saliva formed is less than 3.5 ml, that is unfavorable. 3.5 to 5 ml is marginal, and greater than 5 ml is favorable saliva. So coming to various bacterial count tests which can be done chairside. This is one of the example for a chairside bacterial count test. I will not go in much into detail. As from Ivoclar Vivadent, so which can be used to measure or quantify the Streptococcus mutans as well as Lactobacillus at chairside. Coming to prevention of dental caries. So prevention of dental caries or prevention of new lesions, it depends upon two factors. One is presence or absence of cavitated lesions, and secondly susceptibility of the patients. Prevention can be categorized into two types. Standard care. The standard care is usually advocated for patients with low susceptibility of the caries with no cavitated lesions. Active care is prescribed for patients having higher susceptibility of caries with cavitated lesions. So standard care includes um, asking the patient to brush at least twice a day, the use of fluoridated toothpaste, prescribe interdental brushes as well as floss, and usage of mouthwashes. Active care. With standard care, you also need to manage the salivary factors, which includes hydration. That means asking the patient to drink lots of water, and promoting increased pH as well as buffering capacity. Professional care, which includes oral hygiene prophylaxis, that is scaling, prescribing antibacterial mouthwash such as chlorhexidine, and ART. ART means a traumatic restorative technique, where we quickly remove all the soft carious lesions and replace with either temporary restorations with the glass enamel cement, or more or any other temporary restorations, or you can also go for composite restorations. Okay, focusing more on remineralization through topical fluorides, use of use of APF gel or CPP ACP. These are the examples of commercially available CCP and ACP, like tooth mouse or recurrent gums. Okay, what is this CCP and ACP does is that it increases the level of calcium and phosphate, so acts as a buffer, enhance remineralization, at the same time impedes adherence of Streptococcus mutans to the tooth surface. Coming to the antibacterial varnish, which is Servitec, which is available in gel or liquid form. It contains chlorhexidine and as well as fluoride. You can also go for fluoride varnishes like Fluor Protector, which reduces the sensitivity and also aids in remineralization. Pit and fissure sealants. Pit and fissure sealants help in prevention of dental caries by sealing off the pits and fissures from microorganisms and food debris. Prevention can also be done by modifying patients' dietary habits and lifestyle modifications. There are newer methods of removing dental caries. Examples are fissurotomy burrs, smart prep burrs, sono abrasion, air abrasion, ozone therapy, laser, Caries-Olve, tunnel preparation, slot or box preparation. Then we are going to discuss about the infected dentine versus affected dentine and repair of restorations. Coming to fissurotomy burrs, these are very tiny cone-shaped burrs which remove dental caries very conservatively. Okay, the tip of the burr is very small and prepare very conservative preparation. The fine carbide tip does not very easily and can be used for a very long time. Smart prep burrs. These are experimental burrs made from polymer. The advantage of this burr is that they are softer than sound enamel but harder than the caries tooth structure. So it removes only caries. So we can have a very conservative preparation and retain all the unaffected tooth structure. They are usually used for only single use. You can also use these probe type burrs to remove dental caries. At the end of these probe type tips, there are diamond impregnated, so it removes tooth material by ultrasonic kinetic energy. The working tips, as I said, are coated with diamond on single surface to remove caries. Air abrasion can also be used to remove dental caries. It throws a parallel stream of focused alumina. This fine stream under pressure removes the decay without any drill. It is usually contraindicated in patients with dust allergy or having a history of recent extraction or asthma. Ozone therapy can be used for early treatment of lesions. It controls the disease by using ozone molecules which are bactericidal. Laser treatment, various lasers like erbium, yttrium, aluminum garnet, erbium YAG lasers can be used for preparation of the tooth for restoration for dental caries. Which care should be taken, otherwise it can damage soft tissue. The main limitation of using lasers for caries removal is lack of tactile sensation, therefore may cut more sound dentine. Example which is commercially available is biolaser. There is one more method of caries removal which is called as Carisol. Carisol is a chemical agent which can dissolve the demineralized dentine and then later on which can be removed by spoon excavators. The solution is carefully placed onto the lesion and after 30 seconds wash it off, so the chemical will dissolve the demineralized dentine. You can remove the caries with the spoon excavator followed by replacement with a tooth color restoration. Preparation is a conservative way of restoring the aproximal or the proximal lesions where the marginal ridge is unaffected. So a tunnel is prepared from the occlusal surface, keeping the ridge intact and towards the proximal surface to remove the carious lesion. This is not an easy method of preparing the tooth because there are chances of caries not being removed or else left off at the proximal area. So a not very popular method of restoring a proximal. Slot preparation in slot preparation we prepare conservative cavities to restore the proximal lesions. There is no extension of the preparation onto the occlusal surface like for amalgam preparation where we prepare the outer. So with the advent of more advanced adhesive restorations, so we can do a very small slot preparation to restore proximal lesions. So let's look at the difference between the infected and affected dentine. So what we do is that during a restoration of deep lesions or during deep caries management, we remove the infected dentine and we try to retain the affected dentine which can be remineralized. So how to differentiate between infected and affected dentine? Infected dentine appears moist, soft, pale yellow, whereas affected dentine is a dry, hard and appears brown or black. So infected dentine is having heavy bacterial load, whereas affected dentine do not have any bacteria or may contain few bacteria. So we want to retain this one. So if you look at the histological picture, infected dentine has got more degraded collagen, whereas in affected dentine the collagen is intact. So infected dentine is non-remineralizable, so affected dentine can be remineralized, so it has to be retained when during caries removal. Has to be retained the affected dentine. So there are other options which are available other than directly going for replacement of the restoration. So what we can do is to recontour or polish the margins, seal the margins with sealants and repair the local defect. Only if required we will replace the restoration. If you look at this picture here on the top side, on the top corner, you can see a silver amalgam restoration which appears discoloration around the margins. So there are chances that you may look at it as a secondary caries. So what you do is that first polish off the margins and see if these stains are gone. If you look at this slide, the margins of the amalgam restoration is showing discoloration. So the operator has sealed off these margins with a flowable tooth colored material. So the basic goal of this doing this is to seal off, if there are any bacteria there, seal off this bacteria. So the bacteria gets entombed inside, they don't receive any nutrition, eventually they will die. Okay. So coming to this slide, you can see there is an fractured tooth as well as a fracture restoration. So instead of doing any complex restorative procedure, the operator has done a simple adhesive restoration to repair the restoration. So last but not the least, the most important step I say is a recall or review of the patient after the treatment has been done. If the patient is highly susceptible, we recall the patient every 3 months. If the patient is having moderate susceptibility, we recall after 6 months. If the patient is of low susceptibility, we recall after 12 months for again caries detection procedure and caries management. Thank you all for listening to the lecture. If there are any doubts, please contact me through in the department or through email. Thank you very much.